Welcome to the webinar, Keys to Aesthetic and Prosthetic Success with Dental Implants. This lecture is being presented by Brian J. Goodacre, DDS, and we're going to begin shortly. And with that, it is my distinct honor to introduce Dr. Brian J. Goodacre. He earned his DDS from Loma Linda University School of Dentistry in 2013 and completed a 4.5-year combined prosthodontics and implant dentistry residency, receiving his MSD in 2017. A board-certified prosthodontist, he serves as Director of Clinical Technologies for Nobel Biocare North America and as an adjunct professor at Loma Linda University, teaching dental and graduate students. Dr. Goodacre lectures nationally and internationally on digital dentistry, prosthodontics, and implant dentistry. He also maintains a private practice in Upland, California, where he works alongside his father and former classmate. And with that, it is my pleasure to say, take it away, Dr. Goodacre.
Well, thank you very much for the kind introduction, and I hope everyone joining us tonight is doing well. Again, I can't see everybody, but I know that you're there, and again, I hope you guys are having a great week. And today we're gonna have a fun time talking about the keys to aesthetic and prosthetic success with single implants. And I think it's one of the treatments that we do probably the most of in our practices, and there always are some things we can learn about it. So with no further ado, I do, again, just kind of commercial support disclosure. I do work for Nobel Biocare. So again, you'll see examples of that. However, the principles we talk about, of course, apply to any implant out there. So we'll kind of walk through some specific topics today. So really today we're going to focus on three things, and that's really going to be complications first. And I always find that important to talk about first because it allows us to identify what can happen and therefore hopefully discuss what we can do to avoid that from happening. Then we'll talk a little bit about biomechanics as well as the restoration of the implants as well. And you'll see how those are kind of all intertwined together with kind of the principles that we'll talk about. So let's start with complications. And within complications, the prosthetic complications, it's always interesting to think about the various things that we can face with this type of treatment. And my father, who's a prosthodontist, did a great article a number of years ago that was published in 2003 that looked at the most common implant complications. And that looked at basically from a range of 1981 to 2001. And what we wanted to do was see what happened from 2001 until 2017, which is when we finished the literature review and published in 2018. And we looked at various types of implant complications. Today, we're just going to focus on implant single crowns. But what's really fascinating with this is when you look at the list of complications that we found in that article that we published in 2018, you can see the list of items. And, most of those on this list make sense to us. But what's surprising is even from 2017, when we finished that literature review, till 2026, there's been a change in the order as well as a new number one complication that we see with single implants. And it's kind of fascinating to see how that happens so quickly. And the number one right now is the crown infra position. And we'll go through each of these, but you'll see the first one and the second one are very similar in the range of prevalence that they can occur. So we'll go into more on that. So let's start with the first one, crown infra position, which is again the kind of the new number one, just barely, but still number one. And this is a classic example of this. And that's where a patient is congenitally missing a lateral incisor, in this case, two lateral incisors, and an implant was placed to replace those teeth. And that was probably done at a young age. And then, of course, many years later, a patient can present like you see here, where you see a difference in the incisal edge position of the lateral incisor versus the central incisor. And this is that crown infra position. And what this is caused by is really the idea of that we continue to have facial growth throughout our whole life. And I think most of the time we think this facial growth only happens in that initial kind of teenage years, basically. But the reality is our face continues to change and grow and move in different ways the rest of our lives. And the majority of this change happens in the lower third of the face, which happens to be where we work every day. And growth, kind of in a nutshell, if we try to summarize it, kind of grows along this kind of a path, forward and down, but there are differences. And if you get really deep into the discussions, men and women can have different changes, and the direction of this change can be different. And so it's not always this way, but it gives us an idea of what's happening. And you imagine that with an implant that doesn't move, if the rest of the teeth and the alveolus moves around it, that could be a problem for us aesthetically and honestly bone and tissue wise around implants. And so for some that can be quite a bit, up 3 millimeters. It's even been reported up as much as 5 millimeters. So this can definitely be obviously a challenge for us. Not always is it as extensive as I showed in that picture, but it can be. And here's an example of some of the articles that have discussed this. And of course, there's more than just this, but you can see this gives us a range. And unfortunately, complications have to be reported as a range because everybody's going to have different results, and the literature, unfortunately, will not always agree on the complication rate. So here you can see, that example of, 17%, which isn't too bad, all the way up to 100%. And that's why for some, we may have seen this more than others, and maybe not the case all the time. Um, how do we prevent something like this? There's really no method of preventing infraposition because we can't stop facial growth. The amount that we can see sometimes is very small and sometimes can be much larger, as we discussed. And unfortunately, they've even tried to maybe see if we can predict certain patients that are more likely to have this happen. So let's say you have a dolichofacial patient, the longer face. Is that somebody who's maybe more prone to this happening? Unfortunately, we don't really have that direct correlation. There's some thought that there could be, but really the literature's mixed on that. So we don't know 100% that we're going to always see a direct tie between facial type and the type of growth. But again, there's maybe some thoughts that could happen. So if this does occur, what can we do to really avoid it? If we can't stop it, what can we do to prevent it? Maybe, well, the first thing is to try to avoid placing implants in younger patients. So that would be number one. If we can postpone implants as long as we can until the patients are much older, that gives us the best chance to not have both their initial early growth as well as the remaining growth the rest of their life to both compound on each other, which of course would be a problem. So at the end of the day, what is this magic age? And I wish I could say there's a magic number we can always say, but the reality is the longer we can wait, the better. And so personally for me, I try to wait as long into the 20s as I can. That's easier said than done because patients come in with their parents, they're in junior high or something, and they're done with ortho maybe, and now they really want this missing tooth replaced. So we probably have to, we have to figure out what else can we do to provide a replacement for a tooth that maybe doesn't involve an implant for at least a period of time. And of course, they don't want something removable. So for me, what I like to do is I try to first, if the tooth is still in the mouth, I try to preserve it as long as possible, even if you have to go quite heroic with ortho extrusion or things like that. But if the tooth's already missing or cannot be saved, then we have to look at some other options. And so what I'll do for those patients is kind of go through an example here where we have a younger patient, I think he's 15 years old. And he lost number 9 from a football accident. Unfortunately, the tooth was completely avulsed. Actually, took out, it was like took out some of the buccal bone, and so you can see the amount of missing hard tissue as well as soft tissue as a result of this. And so, he's finished some ortho, but what are we going to do to buy some time for him? And one thing he has to do is improve his oral hygiene. That's number one. But again, that's kind of part of the process as well, of course. So what we're going to do is do a resin bonded prosthesis or a Maryland bridge. And here you can see just an example of that. So this is a zirconia substructure, facially layered to help match the aesthetics of the adjacent tooth. And then this is going to be bonded on to number 8. There's not going to be any bonding to number 10, but just to number 8, it's been shown to be much better in terms of one wing with a cantilever than trying to bond to both adjacent teeth. because of the differences in movement that occurs and some challenges that we can run into with that. So that's what we did for this patient. Again, you have to be very meticulous about bonding this. You have to go over how to clean around it because, again, it's not the easiest to clean. And this patient, again, at his age, oral hygiene is probably not his big priority yet. That will change soon, hopefully. And we've been working with him, and so I've seen him frequently to ensure that. But at the same time, this is a great way to replace a tooth, buy some time, and then in the future, they can do the bone augmentation. They can also do the implant, and we can kind of go from there. And that's kind of the best option. Obviously, we have to protect the occlusion on this because we don't want excessive forces on that specific cantilevered section, but at the same time, we can get a decent, acceptable result to buy time. And that's kind of the ultimate goal. So to manage this, otherwise, when it's already been done, there's a discrepancy in the incisal edge. Well, what we're going to do is work on figuring, okay, well, what are our options to fix this? And so obviously we can replace the existing crown. What you'll find is depending on how extensive the discrepancy is, some patients may not notice this. And so it may not actually be a substantial problem that needs to be replaced. Others, like this picture, that's pretty noticeable. So we're probably going to be doing something about it. So again, remaking the crown is going to be the most common thing that we would do is remake the crown with the incisal edge longer to match the adjacent teeth. If this gets to a point where it's quite long and as you can see in this example, you can see this crown was previously done before the patient came to see me. But again, that's another way we can manage to try to give the illusion that the tooth's not as long as put some pink porcelain. Not the easiest thing to aesthetically match the gingiva. But that's another thing we can do. This patient specifically asked it when she came in if I could remake the crown because what she didn't like, and when you look at her smile, you'll see it's a little more obvious, is she did not like the difference in the shape of number 7 and number 10. And I lucked out that she actually brought the cast that was used to make this crown so I could evaluate the position of the implant. And unfortunately, the implant was a little bit facial. And so while I have a lot of, incisal cervical room or restorative space, the implant position means I can't bring the neck or the facial surface of this tooth more lingual to help make it look smaller just because of the position of it. So for this patient, that was determined that I really couldn't make that much improvement. So we actually left it for now. But you can see that what would need to happen is you'd have to redo the crown, make it more to kind of move that facial contour more lingually on the implant crown. And then if you had to try to balance it with number 10, you might do a veneer or something on 10 with some gingivectomy or something to help balance and mirror that. So again, you have to get kind of creative sometimes. But again, that's kind of the idea behind crown or infra position is you're most likely going to remake the crown. And at that point, you just hope that there's a lower smile line because if they smile really high, not easy to blend this with the natural teeth around it. So that's the first complication or example here that we have 18 to 71%. The next complication is probably when I normally am able to see the audience. This is what more people have seen clinically than crown infra position, even though they may have seen that, is the loss of proximal contact. And here's an example. It's actually from my father, but you can see a 6-year follow-up on an implant crown, and you can see the time of placement and then 6 years later when the proximal contact opened up. And normally the patient is the one that brings this up unless we catch it at a recall exam because they'll mention, food's getting wedged into this area. It wasn't before. And then we take floss and you'll see that it's opened. We have a lot of literature on this topic specifically, and you can see just some of the articles and the range of results that exist there. To just display what we find. From an article side, this is a really great systematic review on this topic specifically. And what I like with the systematic review is it brings up trends by looking at multiple articles. It brings up things that are kind of, I think, very important for us. And so one of them, for example, is there's a higher loss of contact in the mandible than the maxilla. You can see the percentage difference, not a huge amount, but there is a difference. There's a much higher incidence of this on the mesial surface of a crown than the distal surface. So that's kind of interesting to know. It does increase over time, so it's not that it opens and just stops. It can continue to open and get larger. And it's not limited only to, let's say, a patient that had an implant placed at a younger age. This is something that continues on for the rest of your life. So this can happen, but not every patient has this happen at all. So that's again, the joys of some of these things is it's not always going to show up, but it does have a good chance of showing up across our patient population. And there's a similar prevalence in men and women, so nothing different there. So again, just some interesting information I think that's always nice to know. Um, the actual cause of this is probably, again, not 100% agreed upon across the community. And so there are some thoughts of what we call more so the proposed causes as opposed to one specific reason. And I think that's important to know as well. And so one of them, of course, is the facial bone growth. Similar, the same thing that affects the crown infraposition can affect this, of course, and that makes perfect sense. The physiological mesial tooth migration makes sense. If you think about it, how many patients have you seen that have mentioned that they had beautifully straight teeth, and over the years they've kind of got more crooked and crowded in the lower anterior, and that kind of explains there's some migration or movement of teeth. And if you have an implant in place, and then the teeth in front of it move facially or mesially, that would explain why the mesial contact opens more than the distal contact. So kind of makes sense as one of those possible causes. Interproximal tooth wear and migration. This one's kind of interesting and maybe a very small factor, but you never know. I thought it was an interesting one that was proposed. And the idea here is because the natural teeth have PDLs, when you bite down, the proximal contacts will move past each other at different rates. And so over hundreds of thousands of cycles, the thought is that it could wear down the proximal contact a little bit, and therefore the tooth could also drift a little bit. It may be a little far-fetched, but the reality is it probably has some place in which that actually is a factor. And then heavy proximal contacts, another one. So when you think about if you put an implant crown in, and if you've ever tightened screwed an implant crown down, right, and you check the contacts, it's pretty good. Then you torque it into place, and all of a sudden the contact is different. Maybe it's heavier than it was before. That could be orthodontically pushing a tooth in a certain direction. As well as occlusal forces can do the same thing. So I think these are some ideas that could definitely play a role. And then the last one is parafunctional habits as well. So some patients, they clench and grind, that could move teeth as well. So personally for me, I think it's a combination of all of these to some extent. The most common ones for me are probably the first two. But again, it could be a combination of any of these as well. So what are the consequences? Well, of course, we already mentioned food impaction and patients bringing that up. That can lead to periodontal defects on the teeth around it where that open contact exists. It could progress to peri-implant mucositis, where it just irritates the tissue, or it could prolong to a point where it affects the bone around an implant, which is, of course, what we want to avoid any of these, ideally. It can also lead to decay on the adjacent teeth because food gets in there, doesn't get cleaned out, and we can get recurrent decay. So again, something else that we need to really keep a close eye on, just to be safe as well. So those are just some of the things, how we prevent it. One, you can develop a broad contact, and that doesn't mean a heavy one. That just means rather than having a small point contact, if we have a little broader area, that means it might take a little more movement before it just opens right up. But eventually, if it moves enough, of course, that would open as well. Wearing an occlusal guard or an S6 retainer, both of those are going to have a similar effect of holding the teeth in place, and they can be quite as successful at helping us with that. So how do we manage this when it does happen? Well, most commonly, we're going to remake the implant crown. That's probably the number one option there. Um, if, and this would be only if, there's an existing restoration on the tooth next to it, you in theory could cut a little box into that existing restoration and add a filling to it to close the contact. Not saying that's going to be my preferred one, but that could be an option to do this. You could add to the implant crown. A little bit of warning there, of course, would be that anytime you add porcelain to a restoration that's been in the mouth, there's a good chance you could crack or fracture some of the porcelain. And it depends on the material, it depends on so many factors that you can't know for certain if it will happen or not. So you have to let the patient know that this is something that could happen so that they can be prepared for a new crown being made. Now, in this radiograph here, this is a metal ceramic crown. So worst case, you strip the porcelain off and restack some porcelain. But with all ceramic crowns that we primarily use today, that's of course not going to necessarily be an easy thing. You'd have to remake the crown itself. So just some things to kind of keep in mind depending on what options we want to offer patients and which way things just give them that ability to choose. And so I think all of that's possible, but we have to be careful with that. The last one here, and this would be one that I think can work quite well, is we can also treat this like a repair of fractured porcelain. And so we can also condition the surface of the ceramic crown. Again, assuming we know what type of ceramic it is, we would have to prepare it maybe differently. But let's say if it's zirconia, we could remove the crown from the mouth. We can go ahead and air particle abrade the surface that we're going to add to, clean it off very well, and then go ahead and condition the surface. So we use some type of a cleaning surface. Again, the air particle and ultrasonically cleaning helps do this, of course. Then we need to go ahead and add some type of a zirconia primer, which has an MDP molecule in it that helps us create a surface in which we can actually bond composite to. And then we'll go ahead and add a bonding agent as well. And then we can go ahead and put our like a flowable composite, for example. Sorry, we don't need the bonding agent if we use the primer, sorry. But we can go ahead and use the flowable composite to add a little bit and therefore close that contact. So again, various ways we can manage this. And again, the whole purpose is to try to help solve that problem. But most of the time we replace the crown, but we do have some other alternatives as well. What's important, I think, to keep in mind is the first two complications we've talked about, crown infraposition and loss of proximal contact, are two things that we cannot fully prevent. And therefore, we need to really make sure we talk with patients about it so they understand that this will or can happen throughout their life. And that's something that it doesn't happen year one, probably. It can take much longer than that, especially infraposition. So it's something that's good to have probably in an informed consent so that we can have documented that we have discussed that. So those are kind of the first two. And as you can see, similar ranges, as you can kind of see, so very similar, but those are the first two. And personally, for me, I didn't talk as much about the first two of these prior to this kind of more 2023 4 was when I really first found it. And it hasn't changed up till now yet, but that may change soon because it seems to always be on the move. So those are the first two, I think, important to think about because they weren't ones I personally thought about a whole lot. Now, the third one here is where I used to think that was number one. That's the one I talked about. But, abutment screw loosening is kind of interesting. If you go back in the history of implants, in 1993, it was reported that screw loosening was as high as 45%. Now, the reason for that was, of course, they were doing things at that point where they didn't have all the fancy abutments and designs that we have today. So there were a lot of things that weren't as ideal. Primarily, it was the type of screw that was used and didn't allow you to torque it as much as we can today. So you got a lot more screw loosening. Plus, we had a lot less understanding. Now, if we fast forward to 2018 in that article that I published, that's where we really found the reduction go down to 3%. And a lot of this was due to the coatings that are placed on the screws. And so, for example, in this picture, you can see the screws have this kind of black coating on it or color. That's not just for looks. That's actually a special coating called a torque-tight surface coating that allows us to reduce the friction between the threads of the screw and the implant. So when you actually torque the abutment screw, you're actually transferring more of that that torque to the whole complex and actually getting a much better what we call preload, which means you're actually stretching the screw a little bit, which helps clamp the components together. And that's something that when you torque something to, let's say, 35 Newton centimeters, you lose a lot of that torque into the friction of the head of the screw as well as the threads that are down inside the implant. So this helps reduce that. And that's what really has helped reduce the amount of screw loosening. But interestingly, since 2018, this has gone up, and we have reports that go up as high as 15%, which would be pretty significant. So, what are the causes for this? Well, there's a lot of things that tend to do this, and a lot of that comes down to the mechanical overload that we see with implant crowns. And I tend to see this most commonly on the most posterior implant in the mouth when there's not a tooth behind it. Now, it can happen anywhere, but that's where I tend to see it the most, especially when we look in patients that are more what I'd call a hostile environment, where we look in the mouth and we see signs of attrition. So we know that as we have more signs of attrition in the mouth, we have a greater chance of having things like screw loosening occur because of mechanical overload. And here's a great example of, this is a hostile environment of a patient's mouth because look at the wear facets on the natural tooth, and we have this implant there. And we'll come back to this picture at the end. But it's important to see this obviously would need to be adjusted from where we see it in this picture, but we'll come back to that here in a second. And the way I look at this is we also have the scenario in this radiograph that we have a taller crown on a smaller implant. That's not a big problem, but the tall crown can be because as you have a taller crown, think of it like a torque wrench. If I'm trying to torque the lug nut on my car, and I use the little torque wrench on the right side, the socket, the wrench on the right side, I'm only going to be able to apply very little force. Whereas if I use the long torque wrench on the picture on the left, I'm going to be able to put a lot more leverage. And that's the same thing when you have a longer crown, forces applied to the occlusal table have a lot more force they can transfer through down into the implant. And so we can see those problems. We also can have heavy proximal contacts that will give us the illusion that the crown's seated, but it's actually just wedged in. And then, of course, that orthodontically moves the teeth around it, and then the crown becomes loose. That can definitely cause things like fistulas and problems that we have to address. So that's something that we have to watch out for. And of course, the fit of components can also lead to this. And here you can see was a crown of a patient that came in that the crown was loose. We don't know how long it was loose before they identified it and came in and we were able to look at it, but they've completely worn and kind of rounded one of the hex portions of this specific abutment. And you can see the wear on the head of the screw as well, which is pretty significant. So that's one of the downsides is they may not identify it right away. And so we don't know how long it's been in function before they are able to identify it. The other part I always am a big fan of is the focus on using authentic parts versus third party. And the reason for that is when it comes to things like screw loosening and damaging implants, while a third party component will fit into an implant and clinically I won't know the difference. When you look at them under high magnification, there can be significant differences. Not always, but there can be. And it's hard for us to know which ones are better than others. But here's an example. Here's the authentic part, and you can see the surface in which it seals on the connection of the implant and the internal connection of the implant. And then look at the third party. It's about half that size, which means any forces that are applied to this abutment are now going to be distributed over half the surface area, give or take, that the authentic part would be. So that means you have a greater chance of overloading things. The other part is the screws that are used in third-party components may not have the same coating, may not be able to apply the same torque value, and therefore they're more likely to loosen. So you got a combination of things that could lead to screw loosening. And we have a lot of research that's been done on these type of, and they call them commonly in literature, they'll call them clone abutments as opposed to authentic or third party. But when they test these, they're able to see the amount of micromotion or screw loosening that can exist with them. So that's something we just got to keep an eye on. Also, the bone can prevent crowns from seating. That's something else that can cause screw loosening if we don't get it fully seated. So again, just things that we have to kind of keep in mind. The last one really to think about is also that we're applying the right torque value. And that's something that we may or may not always um, be doing this the right way. We may have different types of torque wrenches that maybe need to be calibrated. And that's something that we have to keep an eye on because there's different types of torque wrenches. One where you grab a lever that bends, one in which as you get to a certain value, the head of this torque wrench rotates, indicating you've reached a certain torque. And the problem with some of those, not all of them by any means, but some of them, if you think of all the sterilization cycles that you may go through, there's internal springs and things inside of this torque wrench that may get corroded. Maybe you lose some of that resistance that's needed, and so it may not apply the torque as expected. So just something that we need to keep in mind. For me, anytime a patient comes into the office and there is a crown that's loose, I always make sure I replace the screw. And that's not because I couldn't use screws more than once, but because I don't know how long it's been loose in their mouth, that makes me very nervous, especially if I didn't maybe put the crown in originally, then I don't know the history of that screw, but also the fact that it could be damaged. And so you always want to look at that carefully and evaluate that there's nothing damaged on the screw. And even still, I'd replace it because likely it's been loose for quite a while before the patient identified it. And so as a result, really carefully look at the screw. Here you can see I think I showed this picture already before, but the extreme wear on this screw from it being loose. So that would be one you don't want to reuse. So hopefully that kind of gives you an idea on abutment screw loosening. Again, something that we really want to keep an eye on. And most commonly when we have abutment screw loosening, what causes the majority of it loosening is there's some interference or occlusal contact that we don't see clinically that the patient's able to do somewhere outside of our office. And so it's normally an excursive interference. So we really need to check those lateral movements that the patient can make. The next one is implant fracture. This is one that, of course, is quite detrimental. And, early on, it was a very low percentage, 1% in the 1981 to 2001, and now it's gone up as high as 3% up to 2017 when we published that article. But it's kind of terrifying a little bit is that since then, it's increased even more. And even one implant fracture is catastrophic, let alone the percentages that we see now. And so there's reports of very small ranges, no 0.2%, but all the way, there's also some that go way up into 12%, and that would be quite detrimental. So, why does something like this happen? And what I've found is whenever I've been able to see an example of a fractured implant, there's always some link to either one of these three things. It's either poor planning, poor biomechanics, or of course the environment that the crown is in, meaning, you have a bruxing, clenching patient. And so, implants should be centered. Within the restoration, ideally kind of facing, the long axis of the implant should be facing the functional cusp of the opposing arch if it's a posterior tooth, as an example. And that helps us distribute the force as favorably as we can. For single crowns, the angulated implants where we're off axis loading a single implant can biomechanically be quite unfavorable. So again, that's something that we really want to focus on. And from a biomechanics perspective, we really have four things that we look at the most, and that's cuspal inclination, implant inclination, horizontal implant offset, and the apical implant offset. And so these are the four things that, when you have one of them that's a factor, it can be a problem. But let's say you have two of them or three of them, then you can really be applying a lot of force to an implant where it can, of course, then have a problem where you could see a fracture. And so these are the things that we look at. And so in that section, we talk about biomechanics. This is that key part that we're talking about. So this is really the only thing we're going to focus due to time is just that these are the four things that we really have to respect because what I find is when you have implants that are angled or you have these implants that are not centered under the crowns, you end up with these cantilevers. And this is the worst I've seen, and this picture was shared with me. But the question that was asked when the picture was shared is, well, why does the crown keep loosening? And, it wasn't that hard, I think, to come up with a reason when you look at the cantilever that this has in a posterior site. So this should have a second implant in that cantilevered space because unfortunately, there's not a lot you're going to be able to do to fix this unless you significantly just reduce the mesial distal width of it. But again, that's the key when we look at, biomechanics. That's again a big problem. Of course, we already talked about this, but the fit of components is this another great area to understand that we want something that's designed to fit properly with the implant. So whatever implant system comes into your office that you're making a new crown, that's where I suggest use an authentic part. And that's because the parts that are made by the companies that make the implants, they're designed to fit together. They know all the tolerances. They don't have to guess them. Whereas third-party components, it's not like if you call an implant company, they're going to give you their exact shape. They don't do that. So you have to kind of reverse engineer it, and that's not always going to work well. So again, that's one part of it, not to mention also how the screws work inside the implants that also play a role. So again, those are the things we have to think about. And what we want to do is just kind of reduce the amount of these kind of adverse forces that are applied. So center the implants under the crown. If we have the ability, place a wider diameter implant if you have a wide space, because that's going to allow you to better distribute the forces. I see examples sometimes that are always a little bizarre where you have one implant placed. This was a radiograph from the school where you can see an implant was placed and they made the final crown for that one implant. And unfortunately, the radiograph's not the best representation of it, but it has a large distal cantilever. But yet there's another implant behind it that they could have kind of split the size or the difference. So again, sometimes those are things you have to kind of think about. In this case, I would have splinted them ideally. And in this radiograph, the crown's not even fully seated. So again, some issues going on there. You would also try to decrease the occlusal table, so make it a little smaller so you have less chances of applying forces outside the occlusal table. And of course, careful occlusal adjustment. And then the key one to this is the reevaluation, because just because I adjust the occlusion the day I put the crown in the patient's mouth doesn't mean it's going to stay that way the rest of their life. So we need to keep checking that and make sure that as they wear down their natural teeth around it or the teeth move, we don't end up having all of a sudden a lot of forces on an implant crown that wasn't there before, because that of course can cause this to happen. So that's really the implant fracture side of things. And of course, it's something we want to avoid. Ceramic chipping is one that we're not going to spend a lot of time on. The biggest thing to say about that is this was more common when we had two scenarios, either metal ceramic implant crowns where we didn't have enough metal to support the ceramic, or when we were doing more zirconia crowns and we would layer the whole occlusal and facial or buccal surface with porcelain. And those were things that, again, early on caused some of these numbers that we see nowadays. Loss of retention and decementation is something that we do see if you cement. I personally don't cement very many implant crowns. I like the retrievability of having a screw access hole. But if you do cement a crown, the key takeaway here is make sure that an abutment that you're going to cement a crown on looks like a retentive tooth preparation. Should have parallel walls, with it has to have a little taper, but as parallel as possible, and has ideally a more roughened surface to help give you mechanical locking to that abutment. And so in this specific one, it came back very polished zirconia. So I actually protected the finish line and the subgingival area, and then air particle braided the top part to give it some mechanical undercuts. Or just mechanical retention. So that's something where we really want to make sure that we have adequate height and walls to the abutments, and treat it as if you don't think a tooth, if it was that same shape, could hold a crown. Well, it won't hold it when it's on an implant either. The other factor that we want to think about is we can do other things to avoid cementing in the mouth. And that's where we can do custom abutments, and then we can do screw-mentable crowns. So we still cement a crown, but it has a screw access hole, which allows us to remove the crown and clean the excess cement and make it retrievable. And so that to me is kind of the best of both worlds. And of course, today with things like angled screw channels, it really allows us to not need to cement. And that's why I haven't cemented in many, many years. And just again, personal preference there. But we know that excess cement can be a problem. And here you can see an example of a custom abutment, which nowadays we can mill custom titanium abutments and still have angled screw channels as part of that, which is kind of the best of both worlds. So hopefully from that side, again, we kind of have ways to manage this. My preference, of course, is not to cement if I can help it. And then the last one here is crown remakes. This we're not going to go deep into by any means, but it just means that anytime you do a restoration, there's the chance to need to remake it, whether that could be aesthetic reasons, that it needs to be the shade needs to be adjusted, whether it's the amount of adjustment that's needed because of the occlusion of our articulated records aren't ideal. Whatever it could be, they can need to be remade, and that's why we can let patients know that whenever we're placing a crown, we're trying it in. If it's great, we'll put it in. Otherwise, we may have to send it back to the lab for adjustments, and that kind of sets the expectation for patients, so they're not really hoping that, oh, I'm going to get my crown today no matter what. Well, there's always that chance that we may need to do that. So just those are, I think, are important things for us to kind of keep in mind. So that's really the complication side of things, which again, I think is a very important part to that. From the biomechanics side, I'm just going to very quickly, we talked about the key parts, but the one part I wanted to briefly mention is the difference between anterior and posterior biomechanics really quickly. And the main thing is that with anterior sites or anterior implants, we have the potential that based on the implant diameter, we can actually extend 2 times the implant diameter if we had to. And the only reason I mention this is there are scenarios where we can't put 2 implants in a space and we have to cantilever a lateral off of, let's say, a canine, like we're showing here in this animation. Um, and again, my preference personally is to always avoid those if I can. I don't want to do that, but there's times I have to. Most of the time, it's when I have missing mandibular incisors, where this becomes more common. And so here you can see an example, patients missing 2 incisors. They cannot put 2 implants in that space. So there you can see one example where it was cantilevered. And then here's another example similar where you have the same scenario, an implant, cantilevered the lateral off of it. And again, that's something that we can do. Now, the problem with this is we have to protect that extension or that cantilever, and we really got to be careful with our occlusion because what will likely happen, the most common would be screw loosening. And so for this example, even in this radiograph, we see this patient specifically at 2.5 years, they ended up having some screw loosening. If you look at the hostile environment, look at the wear of the canine. So what happened is initially there was no contact on that restoration, but over time, as the canines wore down, all of a sudden they picked up some contact. And so they had screw loosening at 2.5 years. So again, those are the things that can happen when we do this. And that's where we got to really kind of be careful. Now, when we talk about posterior implants, it's a little different. With posterior implants, because you have a lot more occlusal forces that can be applied, you really have to be extra careful because you can only extend 1 implant diameter in either direction. And what that means is you can have the scenario where if the implant is perfectly centered, let's say a narrower diameter implant was placed in a molar, you could have that scenario where you're already at the extremes of what biomechanics will allow. So that's where we can have a problem. So that's where we either want to have larger diameter implants if we can, because that's going to minimize the chances of us already overloading that. Now, what happens if the implant's not centered? Then we can easily be violating that. And that's where we can see screw loosening and fractures of implants, which of course we want to avoid if we can. So those are the 2 areas from the biomechanics I just briefly wanted to mention that I just think are very important, and understand that anteriorly we can do a little more because we have less forces, but we also have to protect that from any occlusal forces, and the patient has to be extra careful. And personally, for me, I try to avoid it if I can, because anytime you push the bounds, those are the ones that are more likely to cause problems. And unfortunately, I can't say I can always get away from that because there's scenarios where I have to do it. Okay, the last section here is the restorative part, and there's really just four things that we're going to talk about. And really, the first one is abutment options, and this one to me is, of course, always important to consider because we have so many options when it comes to abutments that are available. And most commonly, we use stock abutments, right? It's very commonly used. I personally will use those more posteriorly. Anteriorly, I tend to use more custom abutments because of the scalloping and the shape of the bone and soft tissue. But with the stock abutment, it has a predetermined emergence profile that you cannot modify. And then it has a flat platform in which the laboratory has the known shape of this abutment, and they can mill a crown and then cement it on top of that. And again, these work well, but we have to kind of respect the fact that we don't have full control over that. The other options that we have are, even updates to this that are also important to keep in mind because, like I said, we can't change the emergence profile. And early on, especially some of the emergence profiles of abutments were not as ideal. So here you can see an example of the new emergence profile that you're going to see that allows more room. And you can see the difference between that. Now, the heights, you can choose different heights, but the emergence profile now stays much narrower because implants are placed much deeper than they ever were before. So what this allows you to do is have more room for the bone and soft tissue, and you can see that's been harmonized across healing abutments, scan bodies, as well as temporary and permanent abutments. And that's kind of a key part here to allow us more flexibility when it comes to restoring implants that are placed more subcrestal without impinging on that bone or soft tissue. So those are some things you'll see are coming that allow us to still use a universal abutment, stock abutment, but have better emergence profiles. So just something to kind of keep in mind, and you can see again an example of that. Now, we already talked about screw-mentable abutments. The other thing you'll see are the other types of angled screw channels like we showed before. And that, again, as I mentioned, is what's allowed me not to have to cement crowns for a long time. And this, again, allows me to off-axis tighten the screw. And like even before, you can see there's different ways this can be made. One example is you have this titanium adapter with a screw that clamps the crown onto the adapter and the implant. And you can see an example of that. The one thing I don't like as much about it is because of where the head of the screw is located, the emergence profile has to be a little more abrupt. And so that's where, as we mentioned before, we can also do custom titanium abutments that let us control that emergence profile, determine where the gingival margin will be located, or the finish line of the abutment will be, and we can still cement a crown and have a screw access hole. So while the long axis is in line with this screwdriver right now, we can do angle correction with this. And so that's become my preference for any type of anterior aesthetic cases. I will do an angled custom abutment out of titanium and then cement the crown on top of that. And that gives me the ability to stay very narrow. And here in this one radiograph, you can see the older ASC on the left abutment and then a titanium abutment on the right that allowed me to customize that emergence profile. And again, I think that gives us a lot of flexibility. And again, at the end of the day, those are those main abutments that we use today for these type of restorations. The next thing to consider and talk about is the emergence angle. And emergence angle is something that's got a lot of publicity recently, and I think it's a great topic. But what it's discussing is if we take a line kind of along the long axis of the implant, and then we measure the most prominent point of our emergence profile, and we measure this angle. This is what we call the emergence angle. And what they've found is as this gets greater than 30 degrees, they've found a correlation between a emergence profile greater than 30 degrees and a limited ability for patients to get good oral hygiene access, and therefore we can see a greater chance of peri-implant mucositis or peri-implantitis. They've also done histology studies of the tissues in those areas, and they can also see some changes or differences in the tissues as well. And so we want to think about this in our crown designs that we want to have everything be less than 30 degrees. And here you can see some examples where mesial distally we see this radiographically, but clinically we may not see facial lingually as well. And so we want to make sure that it confines to that. And you can see many examples where it definitely doesn't do that and it violates that. And of course, that could be a problem for multiple reasons. And so what I like to do personally is I like to have crowns, for example, here's a molar, where rather than try to close off these black triangle spaces, I would rather leave them have a nicer emergence profile and give better access for patients to clean. Of course, we hope they actually follow our advice and clean this, but to me, that's a much better scenario to have a nice emergence profile, give the room for them to clean, as opposed to blocking that off and creating almost 90-degree angles, which of course violate that 30-degree emergence angle that we want to see. So just something to keep in mind to look at your restorations and kind of evaluate their emergence angle. The ceramic surface texture is kind of that last one of the last topics here. And what I mean by this is that anything that's going to be below the tissue, so it's going to be subgingival, the tissue really likes highly polished surfaces like zirconia is a great example of that. So that I like to have mechanically polished by hand. I don't like that to be glazed or have porcelain on it. I want it to be highly polished monolithic zirconia. Then anything above that that needs for aesthetic purposes, that can be stained, glazed, layered with porcelain, whatever is needed to get the aesthetic result and the texture you want. And so my ceramist, he does a beautiful job of creating this transition. And yes, it's a little bit below, so a little bit of that's below the gingiva. That's because I don't want to have that line right at the gingival margin. But you can see polishes the subgingival portion, and then he's facially layered the everything above that for the aesthetic result. And so that's, I think, something the textures make sense because if the tissue's happy, it keeps everybody else happy as well. So the last topic that we want to really focus on is the occlusion. And occlusion to me is one of those areas that we probably miss the most in implant dentistry. And really when we look at this, if we're lucky enough with a single implant that it's opposing a natural tooth, that probably is the easiest for us to adjust because the natural tooth opposing it will let the patient know that, oh, I'm biting down hard and I need to do some occlusal adjustment. So that gives us probably the best case to be able to identify and adjust because the PDL also will compress and be a little bit of a shock absorber. But what this means is anytime we adjust the occlusion on an implant crown, we need to adjust it under kind of a tapping, having the patient tap together with normal force, and then also have them do it when they clench their teeth together. And the reason for that is we need the natural teeth to displace because of the PDLs and then show us what occlusion or what comes into contact when they really clench. Because if we adjust the occlusion on an implant crown the exact same way that we adjust a natural tooth, when the patient bites down and they clench, all of their natural teeth will move out of the way a little bit, and that implant crown will be taking all that force. And that's when we can really overload it, especially if it's in an excursive movement as well. So that's where we need to be very careful when we do this. So what we want to do is we're going to have the patient, we're going to have the crown out of contact actually when they lightly or kind of normal tap their teeth together. Then when the patients clench their mouth and the natural teeth are displaced, that's when we can have some contact on that implant crown. And then the amount of clearance that we need for the implant is going to really depend on the patient because one patient, their amount that their PDL displaces may be very minimal, while the next may be a lot. So we do have to customize this from patient to patient. But we know that if we don't do this and we overload implants, there is a point that we can overload the osseointegration of an implant and have an implant failure. If not before that, chipping of porcelain and other problems. But we can extend to the point where we lose an implant because of that. So those are the things we have to really respect. And so here's just an example, the premolars, the implant crown, and here you can see a nicely adjusted implant crown occlusion. So you can see the heavy contacts on the teeth around the implant when they clench really hard. And when they're clenching, there's no contact on the buccal cusp. And you can see three smaller point contacts on the implant when they're clenching down really hard. And at this point, I would love for that to be a little bit more centrally located, but at the same time, that's pretty close and that works well. Now, if we go back to our picture that we showed at the beginning, here's that hostile environment. And so for if we place this restoration, have the patient clench down, and this is what we see, we need to make some changes. And so, for example, we would want to remove everything in these red circles because those are not only heavy contacts, they're actually in a lateral force. So we'd want to remove all of those, and then we want to lighten all of these other contacts, which is a combination of horizontal and vertical movement that's causing this. So what we would do is lighten all of those so they're much smaller, and if we could, keep them as centrally located ideally. So that's kind of what we're looking for when we talk about occlusion is we have to be very protective of these implants. And then more important than anything, to check it frequently because as this patient in this picture continues to wear down their teeth because they clearly don't wear the occlusal guard that they were given, we're going to have to make changes because all of a sudden that implant will come back into occlusal contact. So those are the reasons why we have to be very careful when we do this. So I hope with that, again, I know we had an hour time, so I tried to stick as close as I could to that. I hope with that it went through some important things to consider with single implants. And when we think of the complications that we face with single implants, hopefully we can think of some ways in which we can also avoid them. Because at the end of the day, if we can avoid complications, it makes our lives better and our patients as well.